Well, I hope you will not be disappointed with the following chapter. You will probably expect some kind of a number that you will generate to quantify the severity of MR. I have to disappoint you, there is no such number. Again, we will have to use many different things. We have to put pieces together to come to a diagnosis. This is not much different than the way you judge, for example, the beauty of a car. How can you describe the beauty of a car? Depends very much on your subjective impression and also on your experience. Well, in a way, there is a number you can put to the cars, but that does not necessarily describe the beauty, but only the price. But the key issue here is that we have to use an integrative approach. We will look at the color Doppler, specifically at the jet, but also at the 2D image and observe indirect signs of regurgitation. Every jet in echocardiography has the same components. It has a proximal flow convergence zone, which is the blood flow that moves towards the regurgitant orifice and which accelerates as it moves towards this orifice. To help you understand, imagine you are sitting in a bathtub and you open the stopcock. What will you see? You will see turbulent flow which moves towards the opening, towards the sewage. You will have concentric shells which accelerate the closer they get. This is the flow convergence zone. Back to our jet. The next component we have the vena contracta, which is exactly the blood flow or the width of the blood flow as it passes through the regurgitant orifice. And then we have the jet itself, which has different components again. We can define the length of the jet, the width of the jet, and also, of course, the area. Up front, when you quantify regurgitation, look at the proximal portion of the jet, in other words, the flow convergence and the vena contracta. The remaining part of the jet is important, yes, but not as important as the proximal portions. How does the jet look in echocardiography? This is a still frame where you can nicely see all the components I just described. The proximal flow convergence zone, the vena contracta, and the jet body, where we could actually measure the width, the area, and the length. Not really in this case. Why? Because we have a curved jet. What is very important is you can nicely delineate the flow convergence zone because we have aliasing here. And because we know at which velocity aliasing occurs, we also know which velocity we have right here at the outer shell. This will be important when we talk about other methods to quantify mitral regurgitation. Something else that is important, the body of the jet and the area of the jet often does not correlate with the severity of regurgitation, especially in the setting of asymmetric jets, or so-called wall huggers, where we have jets that blow right into the wall, here for example into the interatrial septum. There we have the so-called Coanda effect. This means that we're losing kinetic energy, momentum and velocity because the jet is directed into the wall. The jet will appear smaller than it actually should be, so we have the risk of underestimating the severity of mitral regurgitation. Again, stick to the proximal portions of the jet, the flow convergence, and the vena contracta. With all the pitfalls that are involved in measuring the jet, here are some reference values for the vena contracta. Mild, below 3 millimeters, moderate between 3 and 6.9, and severe above 7. You can also use the jet area. Here are the reference values. You can see them in the fact sheets. I rarely use these. So here I am. First I tell you there are no numbers to quantify regurgitation, and then the next thing I do is I give you reference values. You're correct. I should stick to the visual assessment. So here are some color Doppler images so I can show you how to quantify regurgitation. Trace. You can hardly see the jet. You can't see vena contracta. You can't see flow convergence. Very small jet. Mild. You can barely see the vena contracta. You really have to play around with the transducer to get it into your field of view. very small flow convergence zone, if any. Here, moderate regurgitation. We do see that there is a fairly broad regurgitant orifice here, or vena contracta. And here, no question, this must be severe, very severe regurgitation. Take a look at these images. Don't forget, you always have to use the assessment in more than one view and practice. Some other things which are important when you assess the jet: the geometry of the regurgitant orifice. Here is the regurgitant orifice in yellow, and obviously it makes a difference if you cut this orifice in this or in this view. Usually, especially if we have secondary forms of regurgitation as in annular dilatation, will the shape be like this, more oval, along the line of closure. So we will always overestimate the severity of regurgitation in a two-chamber view where we cut along the commissure line. Multiple jets. We can have regurgitant here, here, and here. And often we will not be able to have all these jets in one view. So we have to kind of add these jets together and then come to a degree of severity. I already mentioned the Quantification effect. And then finally, the size of the jet also depends on the driving force, systolic pressure, blood pressure, and left atrial compliance. So you can have, for example, completely different degrees of mitral regurgitation depending on the afterload and the systolic pressure. When we quantify the severity of regurgitation, we're actually talking about the amount of volume which is regurgitated into the left atrium. So the time also plays a role, the time during which this regurgitation occurs. If you take a look at this example, here, if you look at the still image or just at one frame, you would probably overestimate the severity of regurgitation because regurgitation does not occur throughout the entire phase of systole, but only towards the end. This is an example which you often find in patients who have bimitral valve leaflet prolapse. In this case, we have competence of the valve until the mid or end systole, and then the valve finally opens. This illustration exemplifies that the amount of backflow into the left atrium depends on the mechanism of mitral regurgitation. We already saw what happens in bileaflet prolapse. We have regurgitation more towards the end. In functional MR, we have an increase at the beginning, then a decrease, and finally towards the end another increase. And in rheumatic mitral regurgitation, the amount of backflow stays the same throughout systole. Let's now put all this information together when we look at the next patient in our demo and when we look at how we can use the color Doppler to look at regurgitation. To quantify mitral regurgitation, it's important to look at many views to really get a good appreciation for the severity of mitral regurgitation. So we'll start with an apical four-chamber view. So this is the jet. It's clear that the jet is very asymmetric. It's oriented towards the interatrial septum. But what is of more interest is the proximal velocity of the jet here before the valve and the vena contracta, which is somewhere here. In this case, we can see that the vena contracta is probably, if we measure it, 0.4 or 0.5 centimeters. So this would correspond to a moderate to severe mitral regurgitation. If we just look at the jet volume or the jet area, we would probably underestimate the true severity. This is due to the Quantification effect. So from this view, you would say it is approximately moderate to severe. But let's look at the other views. This is the two-chamber view. And here, the proximal velocity area of the jet is even larger, which is due to the fact that the jet does not have a circular origin, but probably a more oval origin. So in the two-chamber view, we would probably overestimate the severity, while we would underestimate the severity in the four-chamber view. if we look at the apical view, again, eccentric jet oriented anterior, again, we have proximal velocity jet, which is fairly large, and we can also try to quantify the vena contracta, which is somewhere here. So it's somewhere in the region of 0.5, similar to what we measured in the 4-chamber view. So in conclusion, this is probably moderate to severe mitral regurgitation with an asymmetric jet. There's no question it's important to look at the jet if you want to quantify mitral regurgitation. However, don't forget about the indirect signs. Which signs do I mean? A dilated and hyperdynamic left ventricle, in other words, signs of volume overload, left atrial enlargement, and bulging of the interatrial septum towards the right. But watch out, there could also be another reason for a dilated left ventricle, for example, concomitant aortic regurgitation. Another reason for a dilated left atrium, for example, diastolic dysfunction or hypertension. And for the bulging of the interatrial septum, in other words, other causes of an increased left atrial pressure. But there are also other indirect signs of regurgitation. We'll take a look at those in the following demo. So let's see which additional features a patient with severe mitral regurgitation has. So it's clearly apparent that the left ventricle is hyperdynamic and also dilated. We measured a volume of 205 milliliters end diastolic volume. So classic volume overloaded left ventricle. The next thing we see is that the patient has a dilated left atrium. Just the length of the left atrium is somewhere in the reach of 74, 75 millimeters, so probably also increased risk for atrial fibrillation. Furthermore, we can appreciate that the pulmonary veins are dilated here and here, and also that the interatrial septum bulges towards the right. This is caused by the elevated pressure of the left atrium, and also, in his case, because the jet is directed towards the interatrial septum. In addition, many patients would have pulmonary arterial hypertension. We could measure that with a tricuspid regurgitant jet. However, in his case, the signal is not adequate, so we cannot measure pulmonary pressure. In 99% of the time, you can probably grade the severity of mitral regurgitation based on the jet and the indirect signs. But to be complete, another method is frequently proposed: the retrograde flow in the pulmonic veins. How does that work? Well, the normal flow has a systolic and diastolic component, where the systolic component is larger than the diastolic component, and the retrograde portion of the diastolic flow, which correlates to the atrial contraction, is small. If mitral regurgitation increases, we have an increase of the diastolic component and also that of the retrograde flow. If we have severe regurgitation, we see significant retrograde systolic flow. So the pulmonic signal can be used to assess the severity. However, it's fairly unreliable and it has a lot of pitfalls, and it's technically very difficult to do and time consuming. Now let's turn to the PISA method for the quantification of MR. A very heavily discussed topic, very controversial. Some people are absolute fans, others avoid it. It's almost a religious issue. But before I discuss the pros and cons, we have to understand how it actually works. Remember, we have an increase of velocity as the blood flow approaches a narrowing. We have also an increase as the blood flows to a regurgitant orifice. This shows exactly what happens at a regurgitant orifice. We have concentric shells of velocity as they approach this hole. We know the velocity at the outer limit of this hemispheric shell because we know the aliasing velocity. and we can measure the radius of this hemisphere, and with this information it is possible to calculate the volume that passes through the regurgitant orifice. So this is the famous PISA formula. You can calculate the regurgitant flow by the formula 2 times r squared times pi. This basically is the hemispheric surface, times the Nyquist limit, in other words the Nyquist velocity. Thereby you get the regurgitant flow, while the regurgitant orifice area is calculated also with the use of the maximum velocity of the MR signal measured with continuous wave Doppler. Here's the formula for the regurgitant volume, which is the effective regurgitant orifice area times the time velocity curve of the MR signal. What are the practical issues when you perform the PISA method? First of all, focus on your region of interest, use the zoom. You have less measurement area here. Second, try to use a frame where you can clearly see this hemisphere during systole, where you have the impression that this hemisphere is largest. Next, lower down your lysing limit to 20 to 40 centimeters by also shifting down the baseline. And third, be sure that you have the best image quality available. Here are the reference values for the regurgitant volume, the regurgitant fraction, and the effective regurgitant orifice area. You will find those again in your fact sheets. So okay, we have reference values. The methodology has been proven and shown in many publications that it works. True, the formula is quite complex, but in reality you do not have to memorize the formula. The calculation is being done in the machine anyway. So why don't we use it? Why don't people use it more frequently? Well, in reality the problem is that there are a number of limitations and problems. The first is that the regurgitant orifice is very rarely round, and that it has a different shape than we assume it to be based on the formula. It is not hemispheric, very often it's oval or bizarre shaped. We know that from studies using 3D echocardiography. The second problem is, often do we have multiple jets? How do we account for these? Then, technically it's very difficult often to delineate the PISA. Where is the exact border? The PISA method is unreliable in the setting of eccentric jets, and it does not account for the dynamics of MR during systole. We are just measuring the volume and the flow in one frame. This list is certainly not complete, and on top, probably your ability to image the flow convergence zone is more important than all these factors together. How would I go about? Well, personally, I do not perform the PISA method in patients, maybe for scientific purposes, but not on a routine basis. So even if the theory behind the PISA method is intriguing, I personally rely more on the visual assessment of regurgitation. If I perform it, I always double check with my impression if the numbers fit to what I see. But remember, when I do the visual assessment, I also use the proximal flow convergence zone, so in reality I am also indirectly using the PISA method. Finally, the last technique I want to describe is the volumetric method. The principle is simple. We calculate the volume that goes into the ventricle, we calculate the volume that goes out of the ventricle, and the difference has to be the volume which is regurgitated into the left atrium. However, this only works if we don't have aortic regurgitation. Basically what we do is we calculate the stroke volume across the mitral valve with the help of post-wave Doppler and measurements of the orifice diameter, and the same for the LVOT, and then we calculate the difference, and that is basically the mitral regurgitant volume. Do we use it in clinical practice? Well, actually no. Again, I think in 90% of cases the color flow and the indirect signs are sufficient. For research purposes, if you're interested, yes, it is a methodology, but again, this methodology also has many limitations which I do not want to go into. All along we were talking about chronic MR. Now a few words about acute MR. How do we quantify the severity? Very simple. You look at the patient. Obviously, the patient has to have acute symptoms, otherwise it would not be acute MR. This is a very nice example. A patient who had mitral valve stenosis and who underwent mitral valve valvulopathy. The problem was that we had chordal rupture as a complication and acute severe MR. The specific problem in this situation was that the patient had mitral stenosis and therefore a small left ventricle, which was specifically unadapted to the volume load. So he developed pulmonary edema and, as you can see, tachycardia. So simply by looking at the patient and by looking at the hyperdynamic left ventricle, you can usually make the diagnosis that regurgitation must be severe. Other features include the morphology of the mitral valve. If you directly see the flay leaflet or a papillary muscle rupture, then it makes the diagnosis even more easy. In this case, it was not really possible to directly visualize the problem on the valve, but with the help of color Doppler and continuous wave Doppler, everything was clear. One thing I want to point your attention to, however, is that the color Doppler is not so easy to interpret in the setting of acute MR. Why? Because we have highly turbulent flow both into the left ventricle and back into the left atrium. Often we do not have very high velocities. Why? Because the mitral valve is wide open and because we have low blood pressure. In addition, the patients usually have very high heart rate, and so it makes the interpretation of the color Doppler often very difficult. Therefore, in such a setting, it is often helpful to also use the continuous wave Doppler. What do you see? You see the typical triangular shape of the regurgitant flow, and you see fairly low velocities because the blood pressure is low. Finally, I don't want to leave you alone with all this information without telling you honestly what we do in our laboratory. Well, to tell you the truth, we don't perform very many measurements of MR. Of course, we look at the indirect signs, and we look at the jet, especially the proximal portions, but in most cases we don't even measure the vena contracta or the PISA. And as a matter of fact, if we discuss the severity of MR of patients among the people in our lab, we come to very similar conclusions. So I think visual assessment is as good as we can get. And I'll tell you a secret, many colleagues who propose the PISA method and other quantification techniques, in reality don't do it either in their laboratory. Why do I know? Well, they tell me at the bar in the evening. And still, I do believe that you should know how to use the PISA method and the other quantification techniques. Sometimes it does help. And finally, it would be perfect or wonderful if we had a number where we could really quantify the severity of MR, because I believe that would, in reality, help us to decide what we should do with the patients much, much better than we can at the moment. Maybe this is something that will come in the future.